So Dr. Duckett, welcome very much to Medical Grand Rounds.
Thanks very much. It's a pleasure to be here. What I'd like to talk to you about is Alberta and Alberta healthcare and Alberta health. And I'd like you to think about a Cartesian plane where you can array the Canadian provinces against on an axis relating to life expectancy, for example, and an axis relating to cost per head of population of healthcare. And if you can think about the Canadian average as being in the middle of that plane. And some provinces are above the Canadian average in life expectancy, some provinces are below, some provinces are above the Canadian average in terms of cost per head of population, and some provinces are below. I'd like you to think about where you think Alberta is now. Where on that plane, if you think about it, the bottom, the top left-hand quadrant is the poor performing, above the cost per head of population, and below the Canadian average in life expectancy. The bottom right-hand quadrant is the best quadrant, and the other two are unclear. So you might think about where we are now, and you might think about where we were 10 years ago and how we've travelled, how we've improved, how we've deteriorated. So think about that in your mind, and there's an answer to this. In the early to mid-1990s, Alberta was in that quadrant, lower than the national average in terms of cost per head of population, above the national average in terms of life expectancy. By the late 2000s, Alberta had travelled to this quadrant, below the national average in terms of life expectancy and above the national average in terms of cost per head of population. This is not a good journey. So for the next 5, 10, 15 minutes, I'm going to actually show you that it doesn't matter really what measure you use, you still get the same picture. Healthcare in Alberta has gone downhill over the last decade or so. Compared to other provinces, Alberta spends more per head, uses more health services, and those health services cost more, doesn't provide quicker access or appreciably better population outcomes. Now, I wrote this talk, or I did this analysis when I was still CEO of Alberta Health Services, to help me understand what was the problem that we were trying to solve, what was the issue. And the paper is actually online and has been for a while at that URL. I presented the paper at the Institute of Public Economics here at the university, and I've given the paper subsequently after leaving the job as CEO. So the issue was, it was pretty clear to me as CEO that continuation of the same was not what was going to be good for Alberta. So let's look at the data, and the first half is facts. In 2008, Alberta had the second highest per capita spending of all Canadian provinces, but in 1996 it was lower, and you can see the sort of divergence that occurred over that decade. And when you adjust for the age and gender of the Alberta population, the situation is worse because Alberta has a lower than national average in terms of its age distribution. And you try and decompose this. And so what we looked at, for example, was how was spending going on hospitals and other institutions? Well, over that period, Alberta increased its spending on hospitals and other institutions faster than the other provinces, about 12% faster, for example. But then so other institutions include seniors accommodation and so on. So then you said, okay, well, what about if we distinguish those two, hospitals and others? So Alberta spent 25% more, or increased 25% more than the other provinces in terms of spending on hospitals. Did we get anything for it? Well, we'll come and see. On the other hand, Alberta disinvested in seniors accommodation compared to the other provinces. So in fact, the per capita spend was lower in 2008, after adjusting for inflation, than in 1996, whereas in all the other provinces it was substantially higher. Now you then say, is this a sensible investment strategy in a situation where the population is ageing? Well, pretty obviously not. What is the consequences of this sort of investment strategy where you are underinvesting in seniors accommodation? Well, the answer is obvious, that you'll end up with people in hospitals who don't need to be in hospitals because there are no other facilities. So, what drove the difference? Why is it that Alberta performs so poorly? We'll look at, it could be price, it could be quantity, it could be both. So I'll look at a number of variables here. Let's first of all look at bed utilisation. Alberta provides more bed days per head of population than the other provinces after you standardise for age and gender. Those bed days, if you want to use admissions as a measure, you get the same result. If you want to use the average complexity weighted admissions, you get the same result. This slide shows because we have more admissions, the average weight, the complexity of each admission, is on average lower. So people are being admitted to hospitals in Alberta who would not be admitted in other provinces. Then there's a bit of interpretation in this slide. Because you've got more beds, people tend to stay longer because there's not so much constraint on resources. In terms of unit costs, the cost per complexity adjusted patient is higher in Alberta, obviously. The higher cost is partly driven by more nurses per head employed in hospitals. If you don't like nurses per head as a measure, you get the same answer if you have nurses per patient treated or nurses per complexity adjusted patient treated. We pay nurses more, we have more physicians, we have more family physicians, we have more specialist physicians, we pay the physicians more, we pay more for fee-for-service to physicians, we have more nurses overall, we have more of everything overall. We have more physicians, more nurses, more dentists, more pharmacists, more rehab, more techs and so on. So we've got lots and lots of health professionals. Now what happens within Alberta? So this slide shows the bed day utilisation for those people who live in the city of Calgary and those people who live in the city of Edmonton. You can see that there's about 100 more bed days per 1,000 population after adjusting for age and gender for those who live in the city of Edmonton relative to those who live in the city of Calgary. And to give you an example of what this actually means, if you're admitted for a hip replacement in Calgary, you stay 1 day shorter than if you're admitted for a hip replacement here in Edmonton. Similarly for strokes, if you're admitted for a stroke in Calgary, you stay 1 day shorter than if you're admitted here, with no appreciable difference as far as we can tell in outcomes. The same pattern of quite significant variation in utilisation rates occur across the province as a whole. So Calgary is travelling along there at the bottom, Edmonton down there as well, but then you've got Lethbridge, Medicine Hat, rural north and remote north increasing as you increase in terms of rurality. But what's interesting about this is we see that the Calgary rate is, as you know, the lowest in the province. What's more interesting is the rate of admission of people who live in the city of Calgary is still way above that of people in other Canadian provinces. So even though that is the lowest rate in the province, it is still above the national average or the average for other provinces. So we provide a whole lot of extra services. Well, so we must get something for that. Well, in terms of waiting times, this is waiting times as reported by physicians. There's no real difference between Alberta and Canada, so it doesn't look like we're getting much difference in access. And if you ask consumers to report the same sort of thing, it doesn't look like there's much difference in waiting times. Then it seems to have improved in the last few years, but it's not much difference in actual access that way. In terms of percentage of emergency hip fracture surgery done on the same day, a measure of quality as well as access, Alberta performs worse than the other provinces. Incidentally, you'll notice that the data runs out about 2007-8, which is partly because that's the latest data that was available on a national basis, but it's also interesting because this is before Alberta Health Services was formed. So there's no Alberta Health Services effect in these slides. So there will be. I'm interested in your views in a couple of more slides. Emergency admission performance is pretty bad and deteriorating steadily over the last decade, although these are the proportion of people who were admitted to the wards, the units, within the desired target time of 8 hours. Pretty steady decline, as you can see, at Stollery Children's. pretty flattish over the last 5 or 7 years for the adult hospitals, although steady decline. The same sort of picture applies in Calgary. Average life expectancy, you can see that at 10 years or so ago, the Alberta life expectancy was a twinge or a marginal couple of weeks better than the national average. The gap in terms of life expectancy performance was 6 months or so in the late 90s, but by 2006 or so, Alberta was 3 or 4 months behind the national average in terms, or the average of other provinces, in terms of life expectancy. So that's a significant turnaround in the position. Perinatal mortality was above the national average for most of the period. Death rates from cancer has gone down nationally over this whole period, with Alberta's death rates going down marginally slower than the rest of the country. Alberta's 5-year cancer survival rate is behind that of the other provinces in the 4 biggest cancers that are reported. Satisfaction with healthcare, Alberta has no clear advantage. So looking at the outcome indicators for the health system, our increased spending isn't giving us anything. Now looking at research performance, which is obviously of interest to people here, you can see that Alberta's research income from the Canadian Institutes of Health Research increased over the last decade up to about 2008, when Alberta Health Services was formed, incidentally, and then started to decline. The same too in Calgary. If you look at the picture indexed, you'll see this, inverted commas, Alberta Health Services effect. All the researchers here at the University of Alberta got all upset with me when I said our research performance was poor. And they blamed Alberta Health Services, and you can see it in these graphs. What's interesting about this graph, of course, is the Alberta Health Services effect happened at the University of Montreal as well, and at McGill University, lesser extent at the University of Toronto, to some extent at McMaster, didn't occur at the University of British Columbia. But what's interesting in this slide is if you look at the 2 dotted lines, which are the Alberta hospitals, you can see that they are below the trend line of the other big universities. These universities are the biggest universities in terms of research grants from CIHR. So universities in Alberta's performance for the first few years of this decade was tracking remarkably closely to the other universities, but started to decline in the mid or the early 2000s. So you can see that the research performance is poor too. So what's another summary of what we've seen? We've seen a steady deterioration in performance over the last decade on practically any dimension you care to measure. And it's not just the last AHS years. The demonstrable turnaround for the health system, Alberta's largest employer, will not occur overnight, and you should ignore breathless media statements which imply that a quick fix has occurred. So they're the facts. What I'm now going to proceed with are opinions. So you can take them or leave them. So how did we get into this mess? Well, I gave the same sort of talk in Calgary late last year, and amongst other things I said to the leadership candidates, your predecessors were responsible for a systematic deterioration of healthcare in Alberta. In the version of the speech that I gave. Now, what was interesting were the responses from the leadership candidates. And some of you here will be aware of Kubler-Ross's 5 stages of grief, the first of which is shock and denial. Well, with one exception, that's what the response was. By and large, it was a variation of shoot the messenger, that because I was saying all these things, it must be wrong. Now, people have to move through those grief stages, and the denial is an important stage to work through, as long as you actually work through it. Alison Redford, incidentally, had an acceptance sort of strategy, sort of response. So obviously, I won't make any comment. But anyway, so where have we come from? Well, if you go back to the late 1980s, there are 196 boards of various kinds running healthcare in Alberta and 2 ministries. There was a rationalisation in 88 and another one in 1994 where there were 17 regions and 3 provincial boards. And then the further rationalisation in 2003 where we dropped to 9 regions and 3 boards, and then in 2008 to the single Alberta Health Services. So we can begin to say, there's whether 196 is the right number, incidentally, for a population of 3 or so million is another matter. A former minister that I knew in Australia sort of had a rule of thumb that if there were more board members than there were beds, there was something wrong, and I suspect that was true in some of those areas. So we moved from 128 hospital boards to 17 regions. The regional system had real strengths and talents, but needless structural duplication and waste, what I call Noah's Ark planning. And so everything in Alberta was done 2 by 2. If you had it in Edmonton, you have to have the same thing in Calgary. If you had it in Calgary, you had to have the same thing in Edmonton. The good news is that the Bible story about Noah's Ark wasn't only about 2 by 2. The clean animals went in 7 by 7. And I was very grateful that people didn't remember that, because if you think about it, by the time you add Medicine Hat, Lethbridge, Red Deer, Fort McMurray, Grand Prairie, Edmonton and Calgary, you end up with a 7 by 7 problem. But luckily they only read the 2 by 2. So we had an enormous amount of waste in this failing to rationalise services. We had weak coordination centrally, weak coordination of financial allocations responsive to needs, and significant variation in service delivery choices. And variation in service delivery choices is essentially what regionalisation is about. When you think about it, the point of regionalisation is there can be local variation, that the boards can respond to local needs, and those local needs can vary, and you make different priority choices. And indeed, that's what happened. Whether you think that's the right thing or not is another issue. So here's an example about pap smear participation. So Calgary and the old Calgary region and the old Capital Health region made different choices about the priorities they put on pap smears, for example. And as a result, only 70% of women in Calgary were participating in had adequate pap test coverage versus 74% in Calgary. Same true in 2 of those in the regions in the south. Chinook had a much lower participation rate in pap smear coverage, pap test coverage, than people in Palliser. Again, the question is this appropriate? Are either of those standards appropriate? If we think 74%, 75% is the right is what you can get with optimal coverage, we're looking at quite poor coverage in the Lethbridge area. Another example is about how people paid. So each of the previous 9 regions had responsibility to contract with nursing homes, for example. And this slide shows the result. And we had at least 9 different funding formulae for nursing homes across the province, because some regions had more than one formula, or had idiosyncratic formula for different nursing homes. So here we've got about 180 nursing homes across the province. And what we did was we said, well, we cannot afford to have 9 separate or 20 separate formulae. We have to actually have an equitable basis for funding nursing homes across the province. That meant we had to be able to measure on a consistent basis. And of course, prior to this, the different regions had different ways of measuring acuity, so it took us a while to actually start to measure on a systematic way, in a standard way across the province. As a result of that, we could then do this little graph, which is the amount of money we paid, Alberta Health Services paid, per acuity-adjusted resident of a nursing home. And it varied from $100 to $420 or something dollars per resident after adjusting for acuity. Now, my view was I didn't see how a nursing home could provide adequate care at that lower rate, the 100, 115, 120 rate, and the 420 rate is roughly the same cost per bed day as here at the University of Alberta Hospital. So, we have significant variation, and in the context of needing to address inefficiency, waste and budget savings, This was an area where clearly something needed to be done. So we had various variations in service delivery choices, inability to publish reliable waiting time data because the definitions of waiting times vary between Calgary and Edmonton, for example, so we couldn't publish reliable data. There was weak budget control. So what I call the Gordon-Gekko style of management, that you deal with all problems by asking for more money. And if you don't get the money, it's all the fault of those nasty politicians. But if you think about it, the nasty politicians have got a real problem, because if there is money in the bank, it's very, very hard for a politician to deny a reasonable request for money. And almost always the requests are reasonable. That is, you can always see some good, no matter how trivial, for additional expenditure. And as a result, spending was quite high. So in the first part of this decade, for example, the average annual increase in spend was about 10% per annum. So this is what I would call unsustainable increases in spending, bearing in mind that we got nothing, well, Alberta's performance relative to other provinces went down over this period. The AHS years were about 6% increase in spending. So we come to what I call the Everest syndrome. Do we implicitly or even explicitly reward extra spending or request for extra? It comes from George Mallory's comment about why do you climb Mount Everest? Well, because it's there. Well, why do you spend? Because it's there. I think the previous structures encourage competition for extra money and inhibited good management. I'll give you the example of the negotiations with United Nurses of Alberta. We negotiated a 3-year agreement with UNA, which cost Alberta Health Services, that is, cost Alberta Health Services $120 million over the 3-year period. Phrased another way, because we negotiated that agreement, Alberta Health Services had to find out of its capped budget $120 million for allocation to fund that agreement. The previous agreement, the previous 3-year agreement, cost $620 million, and the way it was funded was the regions went to the government and said, we need an extra $620 million. There was no incentive on the previous regions to actually manage and to be tough or to address some of the efficiency issues and so on in those negotiations. So the very structures did not encourage efficiency and, in my view, inhibited good management. What many people fail to understand is that the Alberta Health Services budget is set by government. This is a democracy, and one of the things that the Legislative Assembly does is actually have an annual budget. And people are supposed to live within that annual budget. Well, that's what I thought. But what was interesting is, as I went around the province as CEO, many people, both within Alberta Health Services and in the media, thought that it was part of my job to criticise the government for the budget it had allocated to Alberta Health Services. So the people of Alberta had come to a political decision through an election about what sort of government they want. That government had made a legitimate decision about how much money it was going to allocate to Alberta Health Services, and then it was up to me, not even a voter in this province, to say, you've made the wrong choice. Well, this is not my conception of a democracy, but anyway. But as I said, I went around the province and people, and a number of staff, for example, said to me, well, why aren't you criticising the government for the budget they've given? And I thought, how peculiar. But anyway, so one of the things that we have to change in Alberta is we need to build acceptance that we do live in a fiscally constrained environment, despite what might loosely be called a fool's paradise, that people think that the wealth of Alberta, the oil wealth, the gas wealth is infinite. And there is a real question for me about whether it is possible to actually build that environment. If you read today's Edmonton Journal, for example, there are 2 letters to the editor basically saying the same thing, that increased tax of any kind, even the so-called sin taxes, and I don't like that phrase, are quite inappropriate. I mentioned earlier that Alberta Health Services is the largest employer in the province. Well, it's probably the largest employer in every city or town in the province as well. So when you're making decisions about fiscal constraint, you're also making decisions about employment. And so rural MLAs especially got quite confused about what the objective of Alberta Health Services was. Was Alberta Health Services' job a rural employment creation job, or was it about managing health services? I thought it was the latter, but obviously that was not necessarily the case. So I think we need in Alberta to build a case that doing better with our existing resources is actually possible, and indeed is legitimate, because some people think it is illegitimate. And the question is, will we be supported in doing that politically? Do we have the skills to do it? And sometimes you need to invest money to save money. And as I said, health expenditure equals health incomes. And I'll give you an example. One of the issues that we dealt with was contracting for cataract services, and this was especially an issue in Calgary. That when we looked at the contracts in Calgary for outsourcing of cataract services, they were developed in a peculiar way, and we hired a consultant at the School of Public Policy at the University of Calgary to actually review the way we contracted for cataracts and said, you know, what's the best way of contracting for services? And they came back and they said, and there's a public document along these lines, if you do cataracts Calgary, I think University of Calgary you might find it, but anyway. So they said that the way you do it in Calgary isn't the right way. And this is the way they did it, essentially, with a few embellishments. There were 5 or 6 cataract providers, and you'd go to tender, you'd get 5 or 6 responses, and then you'd say, hey, everybody can have a contract. And not only that, but we will pay at the average price of those 5 or 6 contractors. Everybody will get the same amount of money. Well, you don't have to be a genius to realise that this has not great incentives for efficiency in it. In fact, it's got great incentives to increase costs. So we went to tender and said, no, we're not going to do it the Calgary way. We're going to do it the way all the other tenders are written. And so we went and had a 2-stage tender process. You had to qualify on quality grounds. If you qualified on quality grounds, then we would decide which were the providers, and in fact we decided that we could get the number of cataracts we wanted with only 3 providers. And in fact, what we did was we said, we are going to spend the same amount of money on cataracts in Calgary as we used to, but because there was a significant drop in price, we were able to increase the number of cataracts done for the same amount of money by 20%. Now, this was then seen as a terrible thing because 2 cataract providers didn't get a contract. Now, then basically there was a huge media furore, and they said, oh, no, you've got to put more money into cataracts. So basically the government said, what you need to do is change the relative priority of cataract spending against all other spending. And there was no concern about the fact that our budget was limited. There was a cap budget, and so we had to spend more on cataracts. Whether that's, well, anyway. So why did performance deteriorate? Well, essentially no bureaucratic oversight. The 2 big regions, Capital and Calgary, and the Cancer Board were very, very politically powerful. There was essentially no transparency or monitoring or benchmarking. I've already mentioned to you the fact that it was almost impossible to compare performance within the province because there were different data definitions. There was a significant emphasis on spin. You know, you arrive at Edmonton Airport and there'd be this big sign saying Capital Health Region is the best region in the world, if not the universe. There was an emphasis on building hospitals, a significant overinvestment on building hospitals. And the question then is, was this partly seen as a legitimate mechanism of spreading the oil wealth across the provinces? You could see it. People loved hospitals. They're good things. There was a high level of political involvement and expectations. And is that partly because there were very, very small rural constituencies, effective one-party government that people bought access in a sense, or could have been seen to have developed relationships over time? And of course the squeaky wheels got rewarded against the voiceless. So the problems are significant in my view, and there's no simple panacea. More money, in my view, is not the answer. Alberta has already tried that experiment and the results are there for everybody to see. However, the population is growing and ageing, and so you need to actually increase your spending on that. I believe that the solution is, and this is a strategy I tried to follow when I was CEO, is that spending the existing money more wisely is obviously part of the solution. Slogans won't work. Privatisation as a slogan, re-regionalisation are all the things that people talk about. In my view, neither of those are the answer. Intervening at any single point isn't enough. It's a big and complex system. And quite clearly, more of the same is not the answer. Winding back the clock is not the answer. Despite our rose-coloured glasses, things weren't all rosy. So basically, coordinated action across a range of fronts is what has to happen. And one of the things we tried to do was start to engage the clinicians, develop the Alberta Clinical Council and the clinical networks, and we said to the clinicians, start wherever you want. The problems are so great, I don't care whether you start on access, quality or sustainability, do whatever you like. What we were trying to do was to change the culture in Alberta healthcare so that we were able to access the structure, what I call the structured collective wisdom of the clinicians versus individual crusades, because there was a view that any doctor who stands up and says anything must be right, regardless of whether they are speaking in their own interests, their own department, or whether they had thought about the opportunity cost issues, the issues of the system as a whole. And so what I was trying to do was to try and get clinicians as a whole and to try and have, in a sense, some peer accountability. The individual crusades, of course, still went on. We need to invest upstream. We need to invest in seniors' care. As I said, there's historic overinvestment in acute beds, but also there's historic overinvestment in the most dependent type of seniors' care. About 75% of the seniors' beds in this province are nursing home beds for the most dependent. And that means that in some parts of the province, you have no choice. If you only need small amount of assistance, you have to go into the most dependent type of care. And so what we wanted to do is change the balance away from the most dependent care to more assisted living, and this, of course, was not universally welcomed. Basically, Alberta needs to open 1,000 additional seniors beds every year to stand still because of the ageing of the population. And we were not doing it in the late 2000s. You have to add more to deal with the backlog. Whether you need to do that into the longer term is, in my view, an open question because of the significant underinvestment in home care as well. I tried to address the issues of Alberta Hospital Edmonton. The physical fabric out there is pretty awful. And then you have to say, well, in the 21st century, is this is this consistent with contemporary provision? And the answer is obviously not. It wasn't successful because of strong union and psychiatrist reaction. We need to actually address things like supporting self-management. The health system is very, very oriented towards acute care when the problems are increasing, that people have multiple chronic diseases and they live with those diseases 24/7, and we need to actually support them and support their carers in actually living with those diseases. We need to encourage learning and innovation. I brought a number of ideas from Australia, for example, but there was substantial xenophobia to my very existence and my role here. Similarly, I brought people from BC who used to work in Alberta just to open up the ideas. As I said, more of the same is not the answer. We had to encourage intra-provincial learning rather than intra-provincial rivalry. You know, Chinook, I think, had a better strategy about seniors care, so we wanted to roll that out across the province. We wanted to have cooperation and sharing versus competition. We wanted to use the expertise that already existed in Alberta and share it across the province. We set quite ambitious goals, and many of them were achieved. We saved $600 or so million in my first year against the $1 billion that the province expected us to. We tried to do, as I said, we had ambitious goals. One of them was to reduce the number of diabetes admissions by a third with provincial strategy and zone strategies. Here at the University of Alberta Hospital, we had the aim of that every person admitted to a GIM bed would have an integrated plan of care within 90 minutes, etc., etc. Anne would say that this has been successful, but you think, bearing in mind the graph I showed you earlier was about people who weren't even admitted within 8 hours. this 90-minute standard was pretty dramatic. I'll give you another story. So I woke up one morning and here I saw in the newspaper that one of the radiation oncologists in Calgary had said that the wait for radiation oncology in Calgary is way too long and we need to have more machines. So I said to the person in charge of cancer care, and bear in mind that the Cancer Board used to have responsibility for both Calgary and Edmonton in terms of radiation oncology, I said, well, is the provision of cancer care radiation oncology efficient? And the measure that we use in Australia is the number of patients per machine per annum treated. And so I asked for that data. Well, it took weeks to come, which suggested to me that no one was measuring that in the past. And when it came on two separate pages, one for Calgary and one for Edmonton. No one had ever stapled it together. It's a pretty sophisticated strategy. Two pieces of paper, a couple of days apart. And obviously there was significant difference between the two. Edmonton actually was more patients per machine per annum than Calgary, and both of them were way below the Australian standards. And so I said, okay, I'm going to hire an Australian consultant to come and give you some advice. I said, oh, no, you can't possibly have an Australian consultant. Anyway, the data were all wrong. So, yeah, I've been there before. Every time you compare people, they always say the data's wrong. So I said, yeah, we'll fix the data. So a couple of months later, they fixed the data. And, of course, the results were the same. Not the same numbers, but the same relativities, and both way below the Australian average. So I said, oh, okay, now we'll hire the Australian consultant. Oh, no, you can't hire the Australian. We'll fix it ourselves, said the Calgary folk. And so, to be fair, they started a process of leaning out their processes and significantly improved the efficiency of radiation oncology in Calgary. The good news is that people at La Crosse did the same. They said, oh, we better get on to this. And they also significantly improved their efficiency. They were still ahead in the end of Calgary. But what was important is we dramatically improved the waiting times for radiation oncology just by making the services more efficient. And the strategy involved those people who are actually working in radiation oncology getting together and identifying where they could improve, make efficiencies. So far from needing to dramatically increase the number of linear accelerators in Calgary, we were able to address some of the problems through efficiency strategies. So what did I think we do right? We were honest, we lifted the lid, we tried to set strategic direction, we tried to develop accountability framework, we tried to end Noah's Ark planning, didn't quite. We tried to develop provincial approaches. What went wrong? Basically there was no pre-merger planning, the first year was wasted, there was no consumer engagement mechanisms at all for the first 20 months. There was significant rural MLA discontent, there was a significant budget cut in my first year, where the community reaction basically said that it's your fault, you must have woken up in the morning and decided to do $1 billion budget cut. There was a vacuum in terms of site leadership, and of course there was a bit of confusion about the role of the ministry versus the Alberta Health Services, and this I think was personality dependent. So I dealt with two ministers in my time, and they were chalk and cheese. So Minister Leipert, his vision or his description of the relationship was an arm's length one. He would say, Alberta Health Services should be at arm's length and they should make the decision. We set the budget, they make the decision. Minister Wozdeski, on the other hand, said there are two arms. One is Alberta Health Services and one is Alberta Health and Wellness. And these were the actual metaphors they used to describe the relationship. And of course, that's the reason I got whiplash in the change of ministers. Of course, maybe the cookie comment was the wrong thing. Maybe it wasn't, for reasons that are not quite apparent. So, where to from here? Don't mess with the structure is my first point. Stop using health spending as a pork barrel. There are other ways of sharing the oil wealth. You shouldn't make decisions based on employment effects. You should actually try and make decisions based on evidence. And that's one of the interesting things about Alberta, that, and maybe Canada healthcare as a whole, the tendency not to use data in your decision making, which then exposes the system to crass political decisions. We need to invest more in community care. It's a theme of what I've been saying earlier. We need to maintain constraint in collective agreement negotiations. We need to give priority to primary care. We need to continue to pursue efficiency strategies, and we don't need to just give up and say it's all too hard, so let's privatise everything in sight. So there are obviously issues. Change takes time. Change appetite varies over time. If you compare Leipert versus Wozdeski, the government basically in the late in November or so 2009 basically said we're going to give up on on the budget cuts. The public perception of the health system is unrelated to its actual performance, and I refer there to the boiling frog syndrome. If you throw a frog in a pot of boiling water, it jumps out. If you slowly boil, the frog stays there. And in fact, Alberta's the latter sort of approach. And of course, the lambs get slaughtered. So this is where we saw where we were before. I think it is possible to get back here, but it requires quite different strategies from what we have been pursuing over the last decade. Thank you very much. Oh, the story, the article, there's an article, as I said, I gave this talk when I was CEO, and that's to be published by the University of Alberta Press later this year. Thank you very much.